Hi friends, today we will be discussing about the management of diabetes, focusing on the management of type 2 diabetes. Management of type 2 diabetes consists of four parts. One is exercise. Next is diet control. Then comes OHA. And finally, it is insulin therapy. In the management of diabetes, the first place is for exercise, next is diet control, then is OHA, and finally is insulin therapy. What kind of exercise for what duration the patient should do? As per ADA guidelines, he should do at least 150 minutes per week of moderate intensity aerobic exercise, and it should be divided over 3 days a week. He should do 150 minutes exercise a week, and it should be divided over 3 days a week at least, and it should be moderate intensity aerobic exercise like jogging. Now about diet control. This diet control is actually a very vast topic, but simply telling that patient should take low glycemic index and a low calorie diet. If some patient or if any of your friends or relatives is asking you, can we eat these dates or can we eat this rice? Then if you don't have any idea about that, just Google it, the glycemic index and the calorie of this food item. If the glycemic index, if it is less than 50, then it is a low glycemic index diet. Than 80, that food is very dangerous for diabetic patients. So about exercise, it is 150 minutes exercise a week. It should be divided and distributed over 3 days a week, and it should be moderate intensity aerobic exercises. And about diet control, the patient should take low glycemic index, low calorie diet. If the glycemic index is less than 50, that diet is good. More than 80, that is dangerous. So if one type 2 diabetic patient comes, first we should advise proper exercise and diet control. If it is not getting controlled with the exercise therapy and diet control, along with this exercise therapy and diet control, we should go to OHS, oral hypoglycemic therapy. So now we are going to discuss about oral hypoglycemic agents. There are different categories of oral hypoglycemic agents. Today we are going to focus mainly on 3 categories. One is biguanides, next is sulfonylureas, and the third one is DPP-4 inhibitors. Biguanides, and we will be focusing on the example metformin. It is mainly metformin category drug. Next is sulfonylurea, and we will be focusing on glimepiride. Then finally is DPP-4 inhibitors, and we will be focusing on teneligliptin. So now we are going to discuss about biguanides, and there is only one main example, that is metformin. Usually the drug of choice for initiation of therapy for type 2 diabetes patient is metformin. Why? Because of its mechanism of action. What are the mechanism of actions of biguanides? Mechanism of action. One is it reduces the insulin resistance. Second is it decreases the hepatic glucose output. As we all know, the main mechanism of type 2 diabetes is insulin resistance. As this metformin overcomes the insulin resistance, we can start treatment with the metformin. And also it decreases the hepatic glucose outputs. Now what are the side effects? Even if you don't know the indications and dosing of a drug, you should mainly know the contraindications and the side effect of a drug. So now about the side effects of metformin. Generally, it is vague abdominal discomfort. Next is diarrhea. Then it is vitamin B12 deficiency, and then finally, the rare side effect, it is lactic acidosis. And now the most important thing about a drug that you should know, that is contraindications. So what are the contraindications for metformin? It is mainly for organ failure. Renal failure, liver failure. Now, severe cardiac failure. It is not the shape of the heart, it is simple representation of heart. And severe respiratory failure. So, in renal failure and liver failure, if the patient is having CKD or liver failure, that metformin is contraindicated. Next is severe cardiac failure and severe respiratory failure. There are two other contraindications. One is metabolic acidosis due to any cause, then it is binge alcohol drinking. So if one patient is having CKD, one patient is having CLD, one patient is having severe cardiac failure or severe respiratory failure, or if the patient is taking heavy amounts of alcohol, or if that patient is having any type of metabolic acidosis, then the metformin is contraindicated. We should avoid metformin in these category of patients. Now about the dose of metformin. Usually we start with 500 mg per day, that is 500 mg OD, and we can increase it up to 3 gram per day. But practically we gives up to around 1 gram BD, that is 1 gram morning and 1 gram evening, that is 2 gram per day. Now the next important category is sulfonylureas. This sulfonylureas acts by increasing the insulin secretion from pancreas. It increases the insulin secretion from beta cells of pancreas. So, first we have given metformin to overcome the insulin resistance. After overcoming the insulin resistance, if sugar levels are not getting controlled, we should increase the production of insulin, and that is done by sulfonylurea category. And now side effects. The side effects of sulfonylureas are caused by this insulin which is secreted due to sulfonylureas, and it is mainly hypoglycemia. Next is weight gain, mainly hypoglycemia, and next is weight gain. Now about the contraindications. It is contraindicated in one is type 1 diabetes. Almost all the OHs are contraindicated in type 1 diabetes. Next is pregnancy. We can give metformin to pregnant patient but not sulfonylureas. Then next is high risk of hypoglycemia. If the patient is having very high risk of hypoglycemia, then it is contraindicated. Then finally is severe renal failure and liver failure. Then here also the sulfonylureas are contraindicated. So we went through mechanism of action, side effects and contraindications. Now we will go to dose of sulfonylureas. We will focus mainly on glimepiride. And we usually start with 1 mg OD, and we can give up to 5 mg per day. Practically we will give up to 2 mg BD. So we start with 1 mg OD and we usually go up to 2 mg BD, that is 4 mg per day. And if it is glycoside, start with 30 mg per day and we go up to 120 mg per day. Just remember the dose of these two drugs. Glimepiride is 1 mg OD to 2 mg BD, then glycoside is 30 mg per day to 120 mg per day. We will discuss the action of DP4 inhibitors. It acts on incretin axis. When sugars or glucose enters from insulin to blood, along with that, these our star incretins are released. These incretins will go to pancreas and it will stimulate the release of insulin. As I already discussed, the sulfonylureas acts by increasing the secretion of insulin. Here the incretins also, it is secreted along with the glucose in diet, and it acts on beta cells of pancreas to stimulate the secretion of insulin. The DPP4 is an enzyme which usually destroys the incretins. But if we are giving the DPP-4 inhibitors, it will block this DPP-4. So the incretins levels go up in our blood and it will stimulate the beta cells to secrete insulin. But there is some difference between the mechanism of action of sulfonylureas and these incretins or DPP-4 inhibitors. The sulfonylureas, if we are giving that to a patient, it will continuously stimulate the beta cells of pancreas and it will continuously secrete insulin from the beta cells of pancreas. But if we are giving DPP-4 inhibitors, it elevates the levels of incretins along with the intake of food. When we are taking food, the levels of incretins are elevated along with that food intake, along with that glucose levels. And this incretins will stimulate the beta cells of pancreas to secrete insulin, and that insulin level is also elevated along with the elevation of glucose levels. So there is less risk of hypoglycemia compared to sulfonylureas. Now, what are the side effects and the contraindications of this DPP-4 inhibitors? It is very easy to remember because it is having almost no side effects and no contraindications. We can give safely to almost all the patients. Now, what is the dose of DPP-4 inhibitors? We will focus on 10 mg. It is 20 mg OD. There is only one drug, one dose with 10 mg, that is 20 mg OD. Now we are going to treat a patients with the type 2 diabetes. If one type 2 diabetes patient comes, we should check the diet history first and we should give a proper dietary advice and then we should give a proper exercise advice. If that patient's sugar level is not getting controlled with this diet therapy and exercise, then we should start on OHS. First we are going to start metformin. Metformin we are starting as 500 mg OD and we will increase up to 500 mg BD if it is not getting controlled, and then we will go to 1 gram BD. If it is not getting controlled with 1 gram BD of metformin, then now we are selecting this glimepiride. We will give glimepiride of 1 mg OD and then 1 mg BD and then 2 mg BD. While giving this glimepiride, we are not stopping this metformin. We will continue metformin. So it will be 1 gram BD of metformin plus 2 mg BD of glimepiride. Now, if it is not getting controlled with this metformin and glimepiride combination, we should go to 10 mg. We should take the help of 10 mg. And the dose of 10 mg is 20 mg OD. So now we have given metformin 1 gram BD, glimepiride 2 mg BD and 10 mg 20 mg OD. If that patient's sugars are not controlled now also. And one thing you have to remember, on each visit you have to recheck the exercise and diet history of that patient. Are you taking proper exercise? Are you doing proper exercise? Are you doing proper diet control? And ask that patient to reduce his weight. The reduction of weight also will help to control the type 2 diabetes. So, if that patient's sugar levels are not controlled with 1 gram BD of metformin, 2 mg BD of glimepiride, and 20 mg OD of 10 mg, we have to use our wonder drug, that is insulin. So, if one patient's sugars are not controlled with 3 OHs in maximum tolerated dose, we should select or we should go to insulin. And when we are starting insulin, we should stop OHs, mainly sulfonylureas, and we can continue metformin. Metformin we continue usually, but all other OHs we usually stop. So for one patient with type 2 diabetes, it is diet control and exercise. Next is metformin 500 mg OD, then 500 mg BD, then 1 gram BD. Now it is glimepiride 1 mg OD, 1 mg BD, then 2 mg BD. Now the patient is on 1 gram BD of metformin and 2 mg BD of glimepiride. And if it is not still controlled, then it is 10 mg 20 mg OD we have to add. After that also, if it is not controlled, now it is insulin therapy, and we should continue the metformin and we should stop all other OHs. We will go to other categories. others. Which are the other categories of OHA? One is meglitinates, like repaglinate. Then it is thiazolidinediones, mainly pioglitazone. Now we have SGLT2 inhibitors, mainly dapagliflozin. Then it is alpha glucosidase inhibitors, that is acarbose or voglibose. And then we can select GLP-1 mellitus, but it is not oral, it is injectable, that is liraglutide. The liraglutide is a wonder drug. It controls the sugar levels effectively, but the problems are, one is it is in injectable form. The next thing is its cost. The liraglutide starting dose is 0.6 mg/d and its cost is around 3,000 to 5,000 rupees. So it will be around 1 lakh to 1.5 lakhs per month. I told you the management of diabetes with the 3 drugs, that is bilipred, metformin and teneligliptin, but you can select any of these repaglinate, pioglitazone, dapagliflozin, voglibose and liraglutide also. Just think that one patient with the type 2 diabetes now who is pregnant is coming to you for diabetic control, or one patient with GDM is coming for diabetic control. You know that most of the drugs are contraindicated in pregnancy, especially most of the OHAs. So you will be confused about which drug to give. Then here is the answer for you. The drug of choice for management of diabetes in pregnancy is insulin. But is there any OHA which can be given? Yes, there is one OHA, and that is metformin. Metformin can be given in pregnancy, and some of the recent studies shows that metformin reduces the incidence of miscarriage, so it is safe in pregnancy. About the treatment of type 2 diabetes in CKD patients. The drug of choice for treatment of type 2 diabetes in CKD patient is insulin always. But if that patient is not willing for insulin, or if there is any barrier to for the initiation of insulin therapy, we can consider some OHS. One is gliclazide. Gliclazide can be given to CKD patients with EGFR of more than 50 to 30. Then SGLT2 inhibitors like dapagliflozin can be given to CKD patient. Then DPP4 inhibitors like teneligliptin and linagliptin can be given. Then acarbose and repaglinate can be given to CKD patient. Drug of choice is insulin, but you can consider these OHs. Thank you.